going to now give you new insights into the medical management.
Thank you, ma'am. So I'll cover the medical management aspect. I have no financial disclosures. The overview of my talk will be based on the three main stay that we have in the medical management. Firstly, the steroid and the immunosuppressants. These are the mainstay of the therapy for a peripheral ulcerative keratitis. Then the biological agents and the newer treatment modalities. So as we know, the PUK may be a harbinger of a serious systemic disease many of the times, so you have to target that disease, and systemic therapy is very important, has very important role in PUK treatment. So main goal of the therapy, as there is an ulcer, so you have to promote the epithelial healing. Plus, because of their immune complexes, there is an autoimmunity aspect in PUK, so you have to halt the stromal lysis that is occurring and minimize the inflammation. And secondary infections have to be prevented. And it has been seen that prompt initiation of treatment reduces the mortality and morbidity, the ocular and the systemic morbidity associated with PUK. So as Dr. Manpreet has very well covered, the causes can be infectious and non-infectious. The first step is to rule out infections. So infection can be a primary local infection, or it can be like a systemic tuberculosis and then secondary manifestation of that infection as a PUK. And non-infectious causes can be underlying, in most cases almost 50% are associated with the systemic autoimmune collagen vascular disease. And when all the investigations are negative and the Watson's criteria is fulfilled, then we label as Morin's ulcer. So management has to be cause specific, and you have to refer many times to a rheumatologist to rule out any underlying condition which can be life threatening as well. This is an important responsibility of the ophthalmologist to refer or liaison with the rheumatologist to initiate a therapy targeting the underlying cause. Many times the rheumatologist may not take the eye manifestation as seriously, and they may not understand that they have to start steroids for an eye manifestation. So there is the role of the ophthalmologist in emphasizing the importance of starting systemic therapy even for the eye manifestation. In local therapy, the antimicrobial has to be started either as a prophylactic or to prevent or to treat any infectious causes. First step is to do corneal scraping, and then the treatment is guided by the culture and sensitivity report of the corneal scraping. So in any underlying systemic autoimmune collagen vascular disease, if you get an investigation positive, so locally you will start lubricants, because there is also keratitis sicca, there is also a keratoconjunctivitis sicca component in these PUK. So lubricants are started. They can be increased up to 1 hourly frequency also, as and when required. Collagen inhibitors inhibitors also are important in local therapy, and acetylcysteine. They are antibiotics, as I just covered, and topical steroids and topical cyclosporine. So topical steroids do not have that much role as systemic steroids. In topical steroids, because they reduce the collagen formation, they can increase the risk of perforation. So in rheumatoid arthritis specifically, the topical steroids are not given for a very long period, or either they are not given. So we have to understand that systemic therapy is more important in PUK with underlying systemic autoimmune disease. And topical cyclosporin has been studied in our center as to have an adjuvant role. There's a study with 2% topical cyclosporin, and it has an adjuvant role in the PUK therapy. So systemic therapy, oral doxycycline can be given to prevent the matrix metalloproteinases that are causing a collagenolysis. And systemic steroids are given to address the underlying systemic condition. They can be given in the dose of 1 to 1.5 mg per kg per day, and they have to be slowly tapered. I'll cover the cautionary aspects with the corticosteroids. Then also we give disease-specific immunomodulators, oral vitamin C to increase the epithelialization, and treat systemic infections like tuberculosis and syphilis. Also is we have to use systemic therapy there also. So aggressive systemic immunosuppression is the main principle. Topical steroids may increase the chances of perforation, and rheumatology consultation for active systemic immunosuppression has to be sought. So any presumed infection PUK, when you send the scrapings, and scrapings are to be taken before starting any antibiotics. So you take scrapings, then you start fortified antibiotics empirically, or you can use a 4th generation fluoroquinolone like amoxifloxacin. Cycloplegic only has a supportive role to reduce the morbidity, and oral antibiotics can be given, the indications being a large ulcer, a deeper ulcer, or ulcer with a stromal infiltration more than 50% depth, and hypopyon or a frank perforation or endophthalmitis. So if you get a culture positive corneal scrapings, so we can treat as per the report, and if we get negative, we can re-scrape after 48 hours of stopping all the drugs. And if even if you give the drug as per the culture report, if there is no response, you can re-scrape after stopping all the drugs. So possibility, if you are getting culture negative, even after second scraping, can be a polymicrobial organism, polymicrobial etiology, an atypical or a drug-resistant organism. And you have to rule out diabetes, any immunocompromised status, an ocular surface disease, and acrocystitis in these cases. And you have to culture in enriched media for atypical organisms, and you require a microbiological support for these enriched media. So if all the reports are negative and it fulfills the Watson's criteria, there's no associated scleritis, no autoimmune disease condition, advancing overhanging edges. So then you can start with the treatment for the Murren's ulcer. So there we have a stepwise treatment protocol. So there's a step ladder. There are multiple steps. So first we start topical steroids for Murren's ulcer. And if there is no response, the lesion is severe, the next step is conjunctival resection. And the higher steps like systemic immunosuppression and additional surgery and rehabilitation. And if there is a clinical response, you have to de-escalate the treatment. So this is the stepwise treatment protocol for Murren's ulcer. For topical steroids are only required with caution in immune inflammatory component of PUK, because there is a lot of local inflammation happening in PUK eyes. So we can use soft steroids like fluorometholone, lotpred, or a high potent steroid like prednisolone, betamethasone, dexamethasone, usually started at 4 times daily dose, and adjusted as per the response. Then the caution I just highlighted, that they inhibit the new collagen formation and do not give for long periods to avoid corneal perforation, especially for rheumatoid arthritis cases. They may go into silent perforation if the steroid is given for a long period, topical steroids. Now, adverse effect can be first perforation, the steroid-induced glaucoma and cataract, and also increased susceptibility to more infections. Adjuvants can be lubricants and cycloplegics, topical collagenase inhibitors like acetylcysteine, anti-glaucoma medications, and autologous serum drops just as a supportive role. Systemic medications is the one I want to stress, that these are the most important for PUK. So for managing the ocular morbidity, we can take help of non-steroidal agents like flurbiprofen, indomethacin, oral vitamin C 500 mg BD for a peripheral corneal to increase the epithelialization, oral doxycycline, and these 3 drugs can help promote development of stable corneal epithelium and to relieve the pain and inflammation that is too much in cases of PUK. And to reduce the overall mortality, we should understand that to reduce the overall mortality, because the PUK is a harbinger of a serious systemic disease. So we have to give aggressive systemic immunosuppressants. So immunomodulatory therapy means starting systemic steroids plus a cytotoxic agent. So systemic steroids are given with a dose of 1 mg per kg and tapered as per the clinical response. One can also take help of a 3-day IV methylprednisolone 1 gram per day in vision-threatening PUK, like in perforated cases where we are sure there's an active disease. So for the acute phase, we can use the IV methylpred also, and we have to add a proton pump inhibitor and calcium supplement to avoid worsening of any gastric ulcer and bone loss, but to manage the steroid side effects. The first step, oral steroids, these give cover till the effect of the immunomodulator starts. That is the second step. So these second step, these are methotrexate, azathioprine, cyclosporin, mycophenolate, and cyclophosphamide. These 5 immunomodulator agents, they take a while for their action to start, and the initial 4 to 6 weeks have to be covered with the oral steroid. So these 2 agents are started together if there is an underlying systemic disease, and after you have ruled out any infection. And also we have to rule out tuberculosis and rule out any uncontrolled diabetes mellitus before starting oral steroids. Third line agent will be these monoclonal agents like infliximab, the etanercept, and the rituximab. So there is a lot of questions among the general practitioners as to which agent to choose, when to initiate the right agent, and how to follow up. So, in initiation of the therapy, it's done usually for a site-threatening disease. So, initiation of immunomodulator therapy is done for site-threatening disease, and in Murren's ulcer, after you have tried the conjunctival resection and it has not given results, also after ruling out tuberculosis and other infections, and you have to start concurrently with steroids. Which agent to choose, it depends on the side effect profile, the underlying disease condition and disease severity. Like if methotrexate has a lot of liver toxicity, and if some person having already underlying liver dysfunction, you don't take that as a first agent of choice. So topical immunomodulator cyclosporin and tacrolimus have only adjuvant role, and they can just help to treat the ulcer fast, but then you have to take help of systemic immunomodulators. So these 5 agents, the methotrexate, cyclophosphamide, mycophenolate, azathioprine, and cyclosporin A, these many times have to be started by ophthalmologist or in liaising with the rheumatologist. So these are corticosteroid sparing agents. So their role is that they reduce the dose of the steroids, or later on we can remove the steroids and shift the patient to only these immunomodulator agents. So corticosteroid sparing agents means that these may be added along with the steroids, and when steroids alone fail to control the disease at less than 10 mg daily dose, or when the steroid toxicity is noted, these agents come to rescue. So careful monitoring is required of drug related and dose related adverse effects, and also especially in the COVID era, we have to alert the patient of these concern with these immunomodulator of increased risk of opportunistic infections. And there is associated risk with patients as therapy is often given for long periods. So I'll cover the side effect risk also. So methotrexate is causes apoptosis of T helper cells. That's how it helps in the PUK. It is a convenient weekly dose of 5 to 25 mg per week. So it is quite preferred because it's an easy once a week dose regimen. And we can taper methotrexate as required. It has liver toxicity, leukopenia. It can cause ulcerative stomatitis. So you have to monitor the blood counts on methotrexate therapy, and nausea, fatigue, and sometimes renal failure. Mycophenolate is also inhibitor of purine synthesis, so it inhibits the replication of T and B cells, or the plasma cells that are releasing the complement proteins, and the T cells are also inhibited, and the chemokines release is reduced with this agent, mycophenolate. So it has twice daily dose, and it with a lot of side effects. And cyclosporin is given in 2 to 3 divided doses. It is also a cancer neuron inhibitor, and the main side effect is gum hyperplasia, hypertension, and hyperkalemia. Azathioprine is a purine synthesis inhibitor. However, it is increasing the predisposition to many neoplasms. For this concern, it is not so much preferred in many individuals, but if the other 3 are contraindicated, you can start the patient on azathioprine. Cyclophosphamide is another agent, which is an alkylating agent basically. So this is a ready reckoner for all the agents. It's available in an article. I'll give a reference. So the steroids and the immunomodulator agents have to be tapered within 8 to 12 weeks, and you have to do 6 weekly investigations of complete blood count, because all these are reducing the DNA synthesis. So you have to monitor blood counts, liver function, kidney function test. ESR and CRP are essential to monitor disease activity. So how the rheumatoid arthritis is controlled with these agents. So, and chest X-ray is also done to 6 weekly to rule out any superimposed infection that would have been invited with these immunomodulator agents. So now third line agent is biological agents, biological therapy. So these are biological response modifiers like rituximab and infliximab, which is anti-TNF alpha blocker. Then anti-interleukin agents, and B cell inhibitors, and targeted antibodies, and intravenous immunoglobulin. These are all third line agents. After the steroids and immunomodulator, this is the third step. So in infliximab, it's an anti-TNF alpha chimeric monoclonal antibody. It's an intravenous administration. Whereas all the others we covered were oral administration. This is intravenous administration, and with a lot of side effects, and have to be monitored. So etanercept, rituximab, and adalimumab are newer biologicals. Side effects include serious infections, activation of tuberculosis, and infusion-related reactions. Interferon alpha 2b has very good response in hepatitis C viral. infections. So Murray's ulcer with, in a case of Hep C positive patient, we can, the drug of choice is interferon alpha 2b. Other agents are also there, named on this slide. And there is a matrix regenerating agent, which is a newer biological agent being used for PUK. So biological therapy or immunosuppressant. So the question is still remains. So in remission phase, that is when you know there is an active disease, you have to take help of steroids and immunosuppressant therapy. In the maintenance phase, you can shift the patient on biological agents. So biological agents are reserved for severe cases of PUK because these are third line agent, as I just described. So when steroids and immunosuppressant fail to control inflammation, then you have to take help of biological response modifiers. So to summarize, the biotherapy is holding promising future, and they are being increasingly used, especially in cases with presenting with perforations. And systemic treatment is reduces the morbidity and mortality, and systemic treatment has to be initiated early in cases of PUK. Further reading, there's a textbook by ma'am and another survey ophthalmology article on PUK. I acknowledge the help from my cornea gurus, Dr. Radhika and Vanati ma'am and Dr. Nupur and Dr. Lomi and Dr. Manpreet. Thank you.
Thank you so much, Yogita. The very nice talk. I'll give a few comments of my own, but meanwhile, I'll request Dr. Lomi to set up his slides on surgical therapy. So as Dr. Yogita nicely covered that there's a whole range of options available. One thing I'd mention regarding to the corneal scraping, it seems a little worrisome because you have a thinned area. It's important to nicely counsel the patient about the importance of the scraping and do the scraping very carefully. Also, even simply putting the speculum in the eye. So be a little bit sensible about which case you're doing, how you're doing it, because if you start putting the speculum and it's extremely thin, it may perforate just at that step right in the clinic. So be cautious. So you have to balance common sense with what is recommended. You may have to adjust the situation depending upon the patient. And the rescraping that she mentioned is if you're very clinically confirmed that it's an infection. With experience, you'll get to know from all the pictures that we show that there is a little yellowish look or a little infected look, and those are the ones, if you still find it to be negative, it's worth going for a rescrape. But as opposed to the normal infective keratitis cases where you'll keep rescraping, here if you get a negative result, then it just may simply be non-infectious. So keep that in mind. Regarding doxycycline, it is a very good help because matrix metalloproteinase inhibitor is a very useful thing to add on. And apart from epithelialization, it helps to further reduce the stromal melting because it reduces the enzymolytic activity. Regarding all the drugs, methotrexate is generally the first go-to that you should remember, but I feel that generally it's always best to work with a physician. It's only if you're really pushed and you have yourself to very rarely I've been the one who've actually started it, though I'm in a multi-speciality hospital and we do have access to all the experts and everything. But once in a while, they will say that, no, we don't think, and you decide. So when they say you decide, then methotrexate is the first thing that you could try. And along with that, you have to prescribe folic acid as well. It happens very rarely that they say you decide. So always good, if you have a lot of patients coming with this, always reach out to a physician colleague. And one more thing that I feel as ophthalmologists, we need to consider doing a trial or at least some kind of a pilot investigation is using pulse cyclophosphamide therapy. Pulse, just like we learned about pulse dexamethasone therapy from the dermatologists, they use it a lot. And they use pulse cyclophosphamide therapy for patients with pemphigus, etc. So this is another thing which you could consider instead of doing once you've stabilized, you can even give once a month cyclophosphamide. So this is something, I'm not advocating it as a therapy, but in case there anybody here who wants to look into it as a worth trying, I feel that this one area of research that is